ಕಾಲಲ್ಲಿ ಕೇಳಬೇಕಾ ಬೇಡ ಅಲ್ಲ ಅವ್ರಿಗೆ ಮಾತ್ರ ತಾನೆ
ಎಲ್ರಿಗೂ ಸೇರಿಸಿ ಹರೀಶ್ ಅನೌನ್ಸ್ ಮಾಡ್ತೀನಿ ಇವಾಗ ನನ್ನ ವರ್ಷದಲ್ಲಿ 2 ನಿಮಿಷ ಇದೆ ಅಷ್ಟೊತ್ತಿಗೆ ಸ್ಟಾರ್ಟ್ ಮಾಡಿ 12 people have logged in. Here they are about
Good evening, everybody. Welcome you all for today's CME. As we are all aware, this is the Carcinoma Awareness Month, and we have a talk on pediatric malignancies by Dr. Vasudha. Her talk is in between obstetrics and gynecology. The obstetrician is going to give us more information about antenatal care, and the gynecology topic will be about some practical aspects which is going to benefit all of us. Kindly bear with us, we'll start in another 10 minutes. Thank you. Good evening, everyone. On behalf of the President and Office Bearers of Family Physicians Association, Bengaluru, I, Dr. Anuradha Parmesh, Vice President, on behalf of our secretaries, Dr. Padma and Dr. Abdul Alim, I am conducting this session. We invite you for this interactive CME this Sunday, 20th February 2022. And as we all know, the topic is on malignancy, because this is the Carcinoma Awareness Month. So the topic is in between two other topics. All the three speakers are, not all the three, the first and the last speaker are going to speak on obstetrics and gynecology respectively. And our prime topic is carcinoma, and today it is going to be on pediatric malignancies. And to give us more information on that, we have Dr. Vasudha, consultant pediatric oncologist. And as we all know, without wasting much time, we've already wasted enough time. We're going to start off with the first topic. First topic is antenatal care essentials. And to give us more information on this, we have Dr. Anita Rao, Senior Consultant Obstetrician and Gynecologist at Rainbow Hospital. To introduce Dr. Anita Rao, I request our Executive Committee member, Dr. Prabhakar. Thank you.
So, good evening, everybody. It is my prestige to introduce Dr. Anita Rao, MBBS, MD, MRCOG. She is MBBS from a prestigious JIPMA Pondicherry, MD from JIPMA Pondicherry, and MRCOG from Royal College of London. She is a very experienced, qualified gynecologist with over 20 years of rich experience and has various academic activities to her credit. So she has a professional membership in Royal College of Obstetrician and Gynecology UK, BSOG and FOSG, and she has worked in various corporate hospitals like Columbia Asia, Cloud9 and Motherhood. Madam, after finishing her post-graduation, has worked in prestigious JIPMA for a short stint and then in St. John's Medical College, and she worked as Assistant Associate Professor in Shahdan Institute of Medical Science, NTR University, Andhra Pradesh. She has a good management experience and she founded the 9th Month Women and Children Clinic in Bangalore in 2012. And she has various specialization to her credit. She is an expertise in complex vaginal surgeries, like vaginal hysterectomy and reconstruction, and she has a special interest in recurrent miscarriage and management and high-risk pregnancies. And she has rich experience in laparoscopic surgeries, and she has presented various papers in national and international forums. Over to Dr. Farah.
Thank you, Dr. Prabhakar, for such a generous introduction. Good evening, my esteemed colleagues. Thank you for having me this evening. Thank you for taking the time out on a Sunday from your family and joining us here. I hope I make this evening a little more interesting. So, we'll have a brief discussion about the essentials of antenatal care. So, let's begin with this beautiful saying which says, you never understand life until it grows inside of you. So true. So, in my formative years as a postgraduate and during my initial years as a resident, my more knowledgeable and learned colleagues, especially neurosurgeons, cardiologists, used to often ask me, what is it that you're going to do? Why are you going to spend so many years training in this? You know the baby is conceived not with your effort. And most of the times it delivers naturally. And in countries like UK, US, we have midwives doing the deliveries. So what exactly do you think you will achieve, or what is your role that you should spend so many years training in this specialty? To all of them, then and now, my answer is, if you have been unfortunate enough, or if you've had the misfortune of having a wife or a close relative or a dear one having gone through the trauma of a miscarriage, or having given birth to an unhealthy baby, or having succumbed to some complication in pregnancy, then you would realize the importance of a structured antenatal care, importance of evidence-based medicine, and how timely intervention could change the outcome and prevent a complication and ensure the birth of a healthy baby which might otherwise be compromised inside the womb. Having said that, obviously the objective of antenatal care would be the birth of a healthy baby to a healthy mother. So easily said than done. For all of us who have started practice more than 2 decades back, we would have seen how patients used to treat us in those days, or we would have seen them treat our seniors almost as God. Every decision we made was accepted without questions, and they were more forgiving, more acceptable. I think that's the best word. But over years, things have changed. That is no longer the scene now. But fortunately or unfortunately, we are expected to perform even better than gods themselves, 100% outcome in everything that we do. They expect absolutely 100% healthy babies every time and absolutely no complication. Even if a woman develops hypertension, somewhere they come back and ask us, what did you do? Did you check the blood pressure properly? Did you not note down the trend of the rising blood pressure? So, and the most common thing that we hear, if a baby is born with even a small defect, they ask, what did you see in the scan? What were the so many scans done for? So to them, my answer is, okay, the essential scans in pregnancy. So we all know that there are 4 essential scans in pregnancy. First is the dating scan or the viability scan, where we see where the pregnancy has formed. If it's in the uterus, we are very happy. And we also look for the presence of a heartbeat, which forms around 6 weeks of pregnancy. Next is the NT scan, where we look for the thickness of the clear space in the back of the baby's neck. So it's not unusual for a space to be seen in fetuses, but if it's unusually large, then it might be an indication that the baby has some chromosomal abnormality like Downs or Patau's or Edwards. Next is the quintessential anomaly scan. This is where we are supposed to perform brilliantly. This is a scan where we look at the structure of the baby from top to bottom, externally, internally, and give a stamp saying that yes, your baby is structurally totally normal. But any scan report, if you see the footnote, it says the detection rate in the best of hands, best of equipment, best of radiologists and fetal medicine specialists is only 60 to 75%. With seniority and even better machines, maybe we can up the figure from 75% to 80%. But it's just that there's a huge 20% margin of anomalies which we cannot detect on scan. Some of them are like subtle abnormalities like polydactyly, external ear defects, microtia, ear tags. I once had a lady who delivered a girl baby with a very small external ear. The amount of crying and wallowing and blame game is still ringing in my ears. She was like, a girl, what did you do in the scan? Did you not see? And for all of it, our radiologist and fetal medicine specialist had only this answer. There's only that much that we can detect. Okay, and cleft lip with cleft palate is definitely easy to detect, but isolated cleft palate, especially posteriorly present, is sometimes difficult to diagnose. Similarly, heart abnormalities like ASD, small VSD, especially posterior muscular wall VSDs, are difficult to detect on an anomaly scan. And unfortunately, some of the defects like musculoskeletal abnormalities, coarctation of aorta, congenital diaphragmatic hernia only manifest themselves at a later stage of pregnancy after 24, 28 weeks. So again, we have a very sorry face to cut to the patients at that point of time. The last important scans are the growth scans, where we measure the growth of the baby and see if it's falling into the norm that is expected of them. We also do Dopplers to assess the blood supply to the pregnancy. And if we note any resistance in the blood supply pattern to the uterine artery and the umbilical artery, then we predict the possibility of a growth restricted baby. So we as obstetricians always have pregnancy in our mind. So even if a 44-year-old woman comes and tells me I'm having night sweats, I'm not sleeping enough, the first thing I ask is pregnancy. So, but for those of other colleagues from other specialties who don't have pregnancy on mind, I implore you to not undermine the importance of the last menstrual period. Now, radiologists in the previous years was asked to follow the rule of 10. That means any investigation or medicines prescribed in the first 10 days of the menstrual period was considered totally safe. But slowly we discovered that organogenesis only happens in 3 to 5 weeks post-conception. So the 10-day rule moved on to the 28-day rule, which means that it is safe to order any investigations, give any medicines in the first 28 days of the cycle, because most of the organogenesis starts only after that. So the shift now is to the missed period. That means any woman who has missed a period is considered pregnant unless proven otherwise. At the same time, it's also reassuring to note that most of our investigations have very low fetal radiation exposure. Like you can see, head neck CT, chest CT, abdominal CT, all also are much less than the critical level of 50 milligray. So only pelvic CT comes anywhere close where the radiation exposure is close to 50 milligray. So all of the exposures less than 50 milligray have very less or minimal chance of abnormalities or miscarriages on the baby. Okay, while we are on history, let us not forget the importance of asking for abuse of alcohol, smoking and drugs. So there were times, maybe 2 decades earlier, 2 decades earlier is when I passed out of MD, so most of my memory is from that time, where they used to say maybe 5 units, less than 5 units of alcohol per week, maybe okay, maybe wine is good for the baby. But now we are very clear, it's a big no. Any amount of alcohol is a big no in pregnancy. And chronic use of close to 5 units per week of alcohol is known to cause the famous fetal alcohol syndrome, where the babies have small head, small brain, cognitive abnormalities and developmental abnormalities. So no to alcohol, and for the similar reasons, no to smoking and no to drugs, absolutely. For women who have previous medical ailments like hypertension, epilepsy, it is very important for us to elicit the history of the medicine use, what medicines they are on. As far as antihypertensives are concerned, we have about 4 safe antihypertensives. So any woman who is on any kind of other antihypertensives, within 2 weeks of the missed period, we would want her to change over to the safe medicines. Those are alpha-methyl-dopa, labetalol, nifedipine and hydralazine. Nowadays, hydralazine and alpha-methyl-dopa are a little difficult to get over the market. So we are now stuck with labetalol, and for acute onset of drop in hypertension, we use nifedipine. Anti-epileptics, carbamazepine, lamotrigine, levetiracetam is absolutely safe. Phenytoin, valproate, phenobarbital are associated with neural tube defects, cleft palate, cardiac abnormalities. But the point to note is, if the seizure control is not good with that absolutely safe medicines, we give the green signal to the physician to go ahead and use the drug that would work most, because the condition of the mother is also equally important, and it's not that it's not an all or none effect. That means use this medicine and the baby will have no. The percentage of having the defects is still very low. So we allow the physician to choose based on the condition of the mother. Antipsychotics, similarly, most of them are safe. Some like lithium should be changed over to a safer medicine. Oral hypoglycemic agents, if the diet and exercise does not work, then we move on to glycomet or metformin as it's commonly called. The safest, highest dose is about 2000 to 2500 mg. So the sugars are not controlled with that, then the next option for her would be insulin. We do not try any other oral hypoglycemic agent. Statins again are a big no in pregnancy. So in early stages of pregnancy, it's important to screen for toxoplasmosis, rubella, hepatitis B, HIV, syphilis. Now we don't screen for toxoplasmosis for everybody unless they give history of handling cat litter or they're symptomatic. Most of them can be treated with medications, and we can reduce the risk of passing the disease to the fetus in utero, except rubella. So that is why we screen for rubella preconceptionally. So whenever a couple comes to us before they've conceived and they're planning to conceive, we screen for rubella. If her immunity is not good or the antibody status is less than the positive level, then we offer her a vaccine, which is just about 150 rupees, and tell them to postpone trying by a month at least. Last but not the least, domestic abuse. They say in India and also most of the developing and developed countries, Domestic abuse is a more common health problem than any of the ones listed above. Domestic violence has a huge impact on the mental and physical health of both the mother and the baby. So it's important to look for telltale signs of abuse in every visit, and if detected, refer her to support groups and to people who would guide and help her. Coming to medicines and vaccines. So we all know that folic acid supplementation is recommended 3 months pre-conceptionally to 3 months post-conception. The recommended dose is 400 micrograms, that is to prevent neural tube defects, prevent microcytic hypochromic anemia. But some women, like those who are diabetic, those who have history of neural tube defects, those on anti-epileptics, require a higher dose of folic acid, that is 5 mg. The vitamin D and vitamin B12 are the in things now. Vitamin D is associated with many things in addition to bone pain and joint pains, to possibility of having a role in the development of PIH, gestational diabetes, recurrent pregnancy loss. So WHO says it is good to supplement, especially dark-skinned women, with at least 200 to 400 international units of vitamin D every day. Now, there are some people who are high risk. In that, of course, is dark-skinned women, those who cover themselves throughout, no exposure to sunlight, obese women, and those who have absorptive disorders, who might require a higher dose of vitamin D. So if we test and see that the value is less than 30 nanograms per ml, then we treat them. That means give a higher dose of vitamin D, from 2,000 to 4,000 international units, or like we normally give 60,000 international units every week. Iron and calcium supplementation is also recommended by WHO. Iron about 30 to 60 milligrams per day, and calcium 500 to 1000 mg per day. Vaccination, we all know that 2 doses of tetanus toxoid is recommended in pregnancy. Nowadays, we moved on from plain TT to Tdap in the second trimester, that's around 24 to 28 weeks. Tdap protects against tetanus, against diphtheria and pertussis. Most babies have the pertussis vaccine around 6 weeks of birth. So this shot around 26 to 28 weeks protects the babies in the first 6 weeks as well. Flu vaccine, especially when the flu is seasonal. Hepatitis B for women who are high risk for developing hepatitis B. That means healthcare professionals or whose partner is tested positive. It is okay to give a hepatitis B vaccine. And now, of course, COVID has joined this list of vaccines. We encourage all the pregnant women to have both the doses of COVID vaccines in pregnancy or preconceptionally. Another common thing which most of the patients' relatives, aunts, grandmothers and mothers ask me is ecosprin. When they see ecosprin on the prescription, they say, but my father took it for heart disease, why are you giving it? Are you sure it's safe? Yes, it's absolutely safe. A dose of 75 to 150 milligram of ecosprin is advised for women who have type 1 or type 2 diabetes, who have had hypertensive disease in the previous pregnancy, those who have chronic hypertension, chronic kidney disease, and autoimmune diseases. Another component which gets added in the list is when we think the baby has a risk of IUGR. We'll look at it later. Okay, nutrition. We as Indians love food, so we have our own mythology regarding foods. We commonly hear girls tell us that my mother said this causes heat, that causes cold. So in allopathy or in our system of medicine, we have no concept of heat and cold. It's a very India-China concept. And now after Wuhan, we don't like anything from China. So if you look at this list, basically there are more things that you can eat than the things that you should avoid. And anything, any food that is eaten raw is best washed well, and the ones cooked is to be cooked well. That is the thumb rule. If they particularly keep on asking me as to what to avoid, then we start this fish, which is high in mercury content. Mercury is supposed to be a toxin, so these sea fish, sharks, swordfish, tuna are better avoided, or have them not more frequently than once in 2 weeks. Similarly, the next thing I say no to is processed junk food. So we tell them don't eat food from outside. Chaats, fruit juices from outside, pizza, burgers are a big no. Alcohol and caffeine. Caffeine being my favorite, I'll tell you more about it. So the safe dose of caffeine per day is 200 mg. And one normal cup of caffeine contains 60 mg. Coffee contains 60 mg. So they can still take 1 or 2 cups and stay within the limit that is harmful. weight gain in pregnancy. Now, this is another major thing coming up in women of our generation who want to maintain themselves throughout pregnancy, who want to look like the film stars or their favorite models. So I've seen so many girls come and say, no, we don't want to put on too much weight, or I'm already a little fat, so should I really put on weight in pregnancy? To all of them, we tell this: if you don't put on, the baby has no way to grow. So you must, otherwise you'll have a baby performing very badly at school or not growing adequately. So then they start really doing what we require from them. So if the BMI is normal, 18 to 25, then about 11 to 16 kgs is expected. So when they see us in the first time itself, we start off 1.5 to 2 kg, 1.5 to 2 kg, but realistically what we expect is around 1 to 1.5 kgs in the first trimester, and after that 1.5 to 2 kg every month till they give birth. Now if she's very lean, that is BMI less than 18, then we expect around closer to 14 to 16, and if she's on the obese side, BMI more than 30, then closer to 11 to 12 kgs. Exercise in pregnancy, another very commonly asked question in pregnancy. So most of the ones, especially when they're trying to conceive, and if they visit us, we tell them, please exercise, lose weight, and you'll conceive easily. So after they conceive, they find it very difficult to give a break. So they'll say, can we start exercising? Can we start walking? To all of them, we say, first 3 months, take it easy, take a back step, because you will have a tough time adjusting to the nausea and vomiting in pregnancy, eating adequately, and maintaining the positive energy balance that is required. So first 3 months, if you manage to eat what is required and do your basic activities, it is good enough. After that, we start them on some kind of moderate exercise, usually half an hour of walk every day. Once they reach the 20th to 24th week, then we have a physiotherapist, and most hospitals have a team of physiotherapists or the ones who are specialized in exercise in pregnancy, who handhold them and at least give 1 or 2 sessions of exercise under supervision, and then they are good to do it at home. Then tips for now, by around 34 weeks, we also teach them squats, so that makes it easy for them during delivery. So another thing we're always asked is, from the time that pregnancy line comes positive in the UP ticket is, I want a normal delivery, I want a normal delivery at any cost. So we tell them normal delivery is for you to do. I have done my part, I have had a child. But for you to have a normal delivery, you must exercise, keep your muscles toned, be active. And during labor and delivery, there are certain things which are not in our control, like if there is a fetal distress, or there is no progress, or if the presentation is not as we want it to be, then it is difficult for her to deliver normally, and it is safest for the mother to have a cesarean. Which also brings us to the next point: what are the indications for cesarean? So if the placenta is low down, placenta previa, or if there are abnormal presentations like breech or transverse lie, or in labor, if she has fetal distress or no progress of labor, then we plan for a cesarean delivery. Now, there are some things that, some conditions which we're very obsessed with, and we screen for it very actively. One of them is gestational diabetes. We all know India is the diabetic capital of the world. So we as an ethnic group itself are high risk for developing pregnancy associated diabetes. So ideally we should be doing that 75 grams oral GTT for every woman at booking itself, but we are more considerate. And if they have other risk factors like BMI more than 30, or previous baby whose weight is more than 4.5 kg, previous gestational diabetes, or a first degree relative with diabetes, then we offer that 75 gram GTT at booking, and then definitely for everybody at 24 to 28 weeks. Other 2 conditions we screen for actively in pregnancies. One is pregnancy-induced hypertension and Iugro, growth restricted babies. For both of them, we have an indication around the NT scan, anomaly scan, where any resistance in the blood supply to the uterine arteries is described as screen positive, and then they started on nicospirin, and then we encourage them to eat highly nutritious food, protein-rich food, and call them for more frequent scans and ask them to monitor their blood pressure at home weekly or once in 2-3 days as required. That comes to the end of the story. So every girl who says, oh, I have been through the trauma or the this one of pregnancy, we tell them the real thing is yet to come. The main story begins after the birth of the child. Being a new parent, sleeplessness, tiredness, exhaustion become your new friends. So I think at the end of the day, we have only this to say, that it's not going to be easy, but it's definitely worth it. Thank you all.
Thank you, Dr. Anita. Well, all of us have benefited from your talk. All the queries right from starting of pregnancy till almost to the end. Yes, thank you very much. That was a very good presentation. I now request our President, Dr. Harish, to honor Dr. Anita Rao. Kindly come. Innu ikkade bani. Thank you. We'll have the question answers in the end. We now move to the next topic, malignancies in pediatric age group. And for that, we have Dr. Vasudha, consultant pediatric oncologist. To introduce Dr. Vasudha, I request our Senior Family Physician Association member, Dr. Usha Rani.
Good evening, friends. I would like to introduce Dr. Vasudha, Consultant Pediatric Hemato-Oncology, Rainbow Children's Hospital, Bangalore. She got RCPCH Fellowship in Pediatric Oncology, Great Ormond Street Hospital for Children, London, UK. Her special interests are brain tumors, neuroblastomas, leukemia. She will tell us about many phases of childhood cancer.
Good evening, everyone. Respected President Sir Dr. Harish, Anuradha ma'am, and esteemed members of the Family Physicians Association Bangalore, and my colleagues from Rainbow. Thank you so much for your time and this opportunity to talk to you about childhood malignancies. So I was just discussing with Anita ma'am, right from a very gentle, topic of antenatal care, we have bounced into something much more serious. And the reason for this is, like Madam was mentioning, 15th of February is observed all over the world as International Childhood Cancer Awareness Day. And why do we need to talk more about this, be more aware about this? I'll try to cover it in my talk in the next 15 to 20 minutes. I'll be just talking about a few cases and trying to convey to you all how this childhood cancer can come with seemingly very normal, very usual complaints, but it turns out to be something much more sinister. The reason why we are talking about this today, every 3 minutes a child is diagnosed with cancer somewhere worldwide. So approximately 4 lakh children every year in the age group of 0 to 19 years worldwide are being diagnosed with cancer. What is the situation in India? About 20% of the global burden is in India. And this is the statistics for Karnataka. If you can see the one that I have marked. So about 3,400 children every year in the age group of 0 to 19 years are being diagnosed with cancer. But what is appalling in this is a study done by CanKids. You can see 50% are not even diagnosed appropriately, and only 1/3, about 33 to 34% are actually reaching a center where they're taking appropriate treatment for cancer. And even out of this 34%, mind you, not everyone will finish treatment. There's problems with abandonment, there's problems with toxic deaths, there's problems with relapses and so on. So what are the challenges with childhood cancer? Like I said, the presenting signs and symptoms are very, very non-specific. So fever is one of the most common manifestations of childhood cancer. Would we think of cancer when we see a child with fever? Never. So we would think of infection first. It mimics more common childhood illnesses. Children are not small adults. They can't really express what's really happening. More so true with infants. access to care is a big problem and treatment abandonment even after they're diagnosed is a problem. But what's the bright side? Children as compared to adults have got really good outcomes when treated appropriately. So about 80 to 85% of them are completely curable. That means their lifespan is as good as you or me. They tolerate chemotherapy really well. And because of the risk stratification and understanding of the molecular genetics over the past a decade or so, we are able to give lesser therapy for children who are less at risk and intensify the therapy for children who are more at risk. So what are the common malignancies in children? Like as you may be aware, leukemias are the most common, followed by brain tumors and lymphomas. And more rarely we see neuroblastomas, renal tumors, retinoblastomas, germ cell tumors and so on. Are there any risk factors? Can we prevent it or can we screen it like we do for adult malignancies? Not really, because there are no environmental factors implicated in the causation of childhood cancer. So childhood cancer, so how does it happen? How does it occur? It's an embryonic origin. Basically, there are cells in the embryonic, in the fetal stage which get arrested in their embryonic stage, and due to reasons that we really do not know, due to DNA changes and mutations, these cells acquire further genetic changes and start replicating. So there's not really any particular test or any particular scan that we can use to actually diagnose childhood or detect childhood cancer early. So less than 5% of childhood cancers have heritable or genetic risk factors. So 95% of them are sporadic. Common symptoms include fever, weight loss, bony pain, abdominal distensions, of course soft tissue swelling, joint pains and headache. So when we talk about is there any causative kind of mechanisms, very few cancers are listed here. For example, osteosarcoma has an association with ionizing radiation. AMLs, if they've previously gotten treated with alkylating agents, or Down syndrome children have a much higher risk of AML. Children with cryptorchidism have a higher risk of malignant germ cell tumor. Preterm children have a higher risk of hepatoblastoma. So there are very few actual kind of risk factors that we can look out for these children. With that, we'll just discuss a few interesting cases. All these cases we have seen in our clinical practice. It just goes on to show us that how childhood cancer can mimic commoner symptoms. So this is a 10-year-old boy. He absolutely well, except for some history of eczema in infancy. Came to his pediatrician with a history of cough for 3 to 4 days with some moderate grade fever. Sounds very much like a viral LRTI, right? So he had some wheeze, sounds very much like a flu. So he had some bilateral bronchi on auscultation. He was given a trial of bronchodilators, antibiotics as well, but came again with a few days of non-resolving cough, increased work of breathing and bilateral bronchi. So even up to this point, it sounds very much like a wheeze-associated LRTI. There were some few cervical lymph nodes palpable bilaterally, but when a chest X-ray was done, you can see that there is definite widening of the mediastinum, and a blood test thereafter revealed that there were numerous blasts in the peripheral sphere. So this child turned out to have a T lymphoblastic leukemia, and T lymphoblastic leukemias, or we call them as non-Hodgkin's lymphomas leukemias, most often present with a mediastinal mass like this. There are imminent dangers of a mediastinal mass. They can cause SVC obstruction revealed by edema and plethora of the face, symptoms of raised intracranial pressure, drowsiness could be there. The most dreaded thing is the airway compromise. So what do you do if you see a child like this who's got a mediastinal widening? Immediately avoid supine position, keep them propped up as much as possible or sitting. Avoid any kind of sedation even for CT scans. So the CT scans should be done in a center equipped to deal with airway compromise because it can actually cause a cardiopulmonary arrest, and even intubation cannot save these children. Anti-TLS tumor lysis measures, hyperhydration should be started preferably through the lower limb because the SVC is already quite compressed by the mass. So when we discuss mediastinal tumors, the most common in children are malignant lymphomas, which are there in the middle mediastinum, and in the anterior mediastinum again we have germ cell tumors and malignant lymphomas. In the posterior mediastinum we've got neurogenic tumors, most commonly the neuroblastomas, that present with cord compression and those signs. So lymphadenopathy is a very, very common complaint in children, especially of the growing age, up to 4 to 8 years, because that's when their lymphatic system actually is growing and maturing. How do we know when to actually suspect that something sinister is going on? Red flags are chronic, persistent, progressive lymphadenopathy. There's no infectious etiology, so look actively for any otitis media, any pharyngitis and things like that. A dominant node that persists for more than 6 weeks should definitely be biopsied. Any lymph node greater than 2.5 centimeter in diameter with no signs of infection and no response to antibiotics. Systemic symptoms, of course. And lymph node location. What do I mean by lymph node location? So obviously a supraclavicular lymph node in a child is a red flag for me. I don't need any of these other criteria also to be fulfilled. So an enlarged lymph node, this is the approach. If it is a suppurative lymphadenopathy, it's quite easy, but if it's no local infection, if there's an abnormal CBC, do a chest X-ray, a supraclavicular, rapidly enlarging lymph node with weight loss and prolonged fever, it is definitely a candidate for either a bone marrow biopsy or a lymph node biopsy. So a word of caution here, FNACs don't give us much information in this regard. A lot of people do FNACs because parents are very apprehensive to do the biopsy. We are only delaying the inevitable. So counsel the parents that excisional biopsy or even a true cut biopsy for that matter will give us much more information than an FNAC. This is the unfortunate child who actually came to us from the from Sudan actually, and this is a 20-month-old child with some alleged history of trauma to the eye. So he kept going to his doctor saying that there's some redness. So this was it, there was some hyphema in his eye. And mother said that the older sibling was actually pricking him with some pen or pencil, or they were fighting or something like that. So once or twice the pediatrician said, okay fine, this could be some traumatic thing, treated conservatively, but again came back with recurrent hyphema. This time he was referred to an ophthalmologist. And this is a slit lamp examination. If you can appreciate, there is a mass in the posterior chamber, and this child actually turned out to have a retinoblastoma. So we are always taught that, you know, white eye reflex is the most imminent sign of a retinoblastoma. The other signs are hyphema, retinal hemorrhages, new onset squints. So this is a typical child with a white eye reflex. The other eye signs that we need to be watchful about are, this is a child with what we call as raccoon eyes. We would have read it in our MBBS, right? Raccoon eyes, bleeding around the facial muscles. Sorry. And a new onset squint. Again, if a child is born with a squint, that's something else. But if a child who is 3 or 4 years old is brought with a new onset squint, it is a big red flag sign for a brain tumor and double vision, which older children may actually complain of. This is another very unfortunate girl, a 3-year-old girl, absolutely well until then, some back pain for 3 months. So again, this is a very weird history. Why should a 3-year-old child have a back pain? So she had some low-grade fever and intermittent episodes of vomiting. There's preceding history of road traffic accident. So the mother told us that after this accident itself, she started having back pain. So people attributed to probably some kind of blunt trauma, blunt injury. An MRI was done that showed some mild anterior wedging of the lumbar and lower thoracic vertebrae. Bone scan was normal. This child actually came to my rheumatology colleague because they were thinking of some kind of rheumatological ankylosing spondylitis, etc. And these are investigations. HB is absolutely normal, WBC normal, differential is also normal, platelets are normal, except for an elevated ESR. And of course, your serum calcium is highly elevated. So what do you think of this? Could it be a malignancy? So yeah, bone tumor is a possibility, but the MRI did not really show us much, sir. It was just like some wedging. We did not actually consider any malignancy in this child, but to our surprise, for the hypercalcemia, she was started on hyperhydration and zoledronic acid. We did a chest X-ray just to work out pyrexia of unknown origin, and our radiologist was very smart enough to show us that there are some translucent bands here. I'm not sure if you can appreciate it. And she actually implored us to do a bone marrow evaluation, and bone marrow showed 90% blasts in the thing. So this was actually a learning lesson for all of us that a normal CBC need not actually rule out leukemia. Musculoskeletal symptoms, when do we need to be concerned about? Severe enough to interfere with sleep, severe or persistent back pain. Of course, there are signs of cord compression. You could be leukemia, NHL, neuroblastoma, Ewing's, LCH, all of them can present like this. The problem with children is that pain is often initially attributed to growing pains. So there's always a delay in diagnosis. Recently, last week, we had a little boy, a 4-year-old, who kept going to the doctor saying that he's limping and he has pain in the left leg. So he was treated as viral myositis, given steroids, given vitamin supplements, etc., etc., etc. And then he came to us. And when we evaluated him, unfortunately, he had a metastatic neuroblastoma. So that was he had mets all over his body with a big palpable mass in the abdomen. So a limp in a child is to be taken seriously, definitely has to be evaluated for malignancy. So this is just a flowchart for acute swollen hip, and please have malignancy in your differentials, especially because these children are sometimes started on steroids because they're thought of rheumatological disorders. And if you have your leukemia, it is going to respond to it. So always try and do a bone marrow examination before you start the child on steroids. And most studies say that in up to 40% children of ALL, pain was the only symptom. And what was more appalling in this is that children with pain had relatively normal CBCs. So if you've got bony pain, you may have a normal CBCs even if it's a leukemia. So 1/3 of them had no blasts even on the peripheral smear. And younger children, like I said, may just present with a limp, refusal to walk, or arthritis limited to one joint. So what are the indications for bone marrow examinations? Of course, cytopenias of one or more lineages on the blood, presence of blasts, presence of leukoerythroblastic changes on peripheral smear, if there's lymphadenopathy and hepatosplenomegaly, if there is an anterior mediastinal mass, and like this case showed us, if there's clinical suspicion, it is a very non-invasive test. It can be done under sedation. It's a test that takes 10 minutes. Please implore the parents to do a bone marrow examination. Coming to brain tumors. So this is a 20-month-old boy with a 7-month history of failure to thrive. So he was okay until about a year. Thereafter, not gaining weight. Mother says that he's eating properly, but still not gaining weight. Evaluated thoroughly for that, dietitian consult taken, an echo was done. Is there a missed cardiac disease? Finally, endocrine was consulted, and they said that his bone age was really advanced as compared to his age. For that evaluation of advanced bone age, an MRI was done, and this was his MRI. You can see that there's a hypothalamic tumor sitting over here, causing all the signs which we refer to as Diencephalic Syndrome. So this is a kind of syndrome seen in infants with a hypothalamic or a optic pathway glioma. Because of the hypothalamic involvement, they feel so hungry that they eat a lot, but because of the hormonal imbalances, their bone age is advanced. They don't tend to gain weight at all. And this was described way back. If you can see the description, it's a bright hyperkinetic youngster who smiled a great deal. He walked only with support and did not talk, and his vision and visual fields were bilaterally normal. These children can also have nystagmus because of involvement of optic nerves. So you can see it's a very, very well child. Would you think of a child who is like this actually having a brain tumor? The intracranial lesions, again, a big problem. They're very non-specific in symptoms. In younger children especially, enlarging fronto-occipital circumference. So measurement of head circumference is very, very important. Chronic recurrent headaches, vomiting, visual disturbances, changes in behavior or school performance. So of course, specific signs like hemiparesis, cranial nerve palsy, seizures, they're more easier to evaluate. So what kind of headache do we need to be concerned about? Recurrent early morning headache, headache that awakens the child, intense and incapacitating and associated with vomiting. Focal seizures or atypical febrile seizures in an 8-year-old child, who's coming with fever triggered seizures. Again, something is not normal. This child needs a neuro imaging. Of course, abnormal neurological findings and clinical examination. This is my last case scenario. This is a 5-year-old, previously well girl, fever on and off since 1 month, cough since 15 days, breathlessness since 5 days. Again, sounds very, very infectious. The first thing that would come to anyone's mind is tuberculosis. And of course, there is a history of pulmonary tuberculosis in her grandmother 1 year ago. On examination, a very malnourished child with significant increased work of breathing and bilateral crepitation. So malnourished child, contact with TB, this is a perfect recipe for tuberculosis. That's what we also thought. And when we did an X-ray, there were infiltrates in bilateral lungs, but sputum or GL for AFB was negative. But we do know that children can have, paucibacillary TB. So we still went ahead and started her on ATT. But she was not improving symptomatically at all. One fine day, she developed acute onset of worsening breathlessness with drop in saturations. And she turned out to be having a pneumothorax on the left side. So the chest tube was inserted, she was in the PICU. We were wondering if she's MDR tuberculosis, why is she not improving at all? And finally, we did a CT scan of the thorax. When we did a CT scan, you can see these, bullae, I'm not sure if you can see it, everywhere. And a very honeycombed appearance, all sizes of bullae here. And again, the radiologist actually helped us here. And any guesses for the diagnosis? We did an X-ray of her skull thereafter. It was histiocytosis. So it was a Langerhans cell histiocytosis with pulmonary involvement. And she was started on steroids and vinblastine and did very, very well after that. So this is my take-home message. There are a few warning signs: pallor, bruising, bleeding, or generalized bone pain, lumps or swelling without any other signs of infection, unexplained weight loss or fever, persistent cough, sweating at night, new eye changes like white pupil, new onset squint, visual loss, bruising or swelling around the eye, abdominal swellings, headaches, especially if persistent or severe, vomiting, especially in the early morning, a limb or a bony pain without any signs of trauma or infection again, fatigue, lethargy, changes in behavior, and dizziness, loss of balance of coordination. This is by the International Childhood Cancer Control. They have made a poster so that more and more people can actually identify at all levels, not even just at a hospital level, a tertiary care, even a primary care level. They can identify these signs and refer these children at the right time. With that, I come to the end of the talk. If there are any questions, I'm happy to take them.
I have to check in the chat box also.
Sure.
So we'll have the questions together.
Sure.
Yeah.
Thank you.
And together we will take both the live and thanks for that elaborate presentation and highlighting on the ominous signs. So when the child comes back to us with the same problem again and again, we need to reevaluate. Thanks for the putting in those take-home messages for us. I request our past president, Dr. R.S. Raju, to honor Dr. Vasudha. This also. Thank you. Thank you. So we move on to the last topic. So antenatal care, and as Dr. Vasudha put it, we went into malignancies and now we are going to come back to gynecology. So Dr. Swaitha Kamath, consultant lab surgeon, is going to give us more information about changing concepts in gynecology. And to introduce Dr. Swaitha, I request our scientific chairperson, Captain Prabhakar, past vice president.
Good evening, friends. It gives me immense pleasure to inviting you all. Welcoming you all to this last talk of the day. It's quite, though I must say that we are going to miss, most of us are going to, very unlikely to have missed the last topic. I find only very few of us are here. I know because attraction is some other place also, anyway. So having said that, it's my pleasure and privilege to introduce Dr. Swaitha Kamath. She's a very dynamic obstetrician and gynecologist and a laparoscopic surgeon. She has got a wide experience of 14 years in the field, having completed an MBBS from MS Ramaya and her MS in OB-GYN from JIPMER in 2012. Since then, she has been working in a lot of local hospitals in Bangalore, like Warmam Hospital, LTS hospitals. and she's also specialized in gynec laparoscopy and infertility. She has performed complicated lap surgery procedures like multiple fibroid removals, endometriosis, lap in pregnancy, etc. She's also an infertility specialist with good outcomes in IVF, including low ovarian reserve, previous IVF failures, thin endometrium, donor surrogacy, etc. She also manages high-risk deliveries, complicated pregnancies like recurrent abortion, diabetes, twins, hypertension, medical problems, whatever, any problem in pregnancy related, Dr. Swaitha is there to tackle, and no worry for any person with complicated pregnancies. So before much ado, I think I welcome Dr. Swaitha Kamath to the floor. Welcome, madam.
As we are organizing the third talk, any questions? Question? Yeah. Shall I read it out? Yeah, Mike. No. Online also they have to listen to you. Kindly come here.
No, this is the food during pregnancy. Madam told some food to be selectively to be avoided. And I just saw that unpasteurized butter. Then I showed cheese also. What is the connection between cheese and the pregnancy? Just like to know.
Unpasteurized cheese is very popular with the infection called listeriosis, so we are not very happy with that. So, more risk for listeriosis. So. No, so it's very widely known that unpasteurized cheese is a risk factor for contracting listeriosis. So we don't want them to. Not really. That's what I said. So to all the girls, we tell, please wash your food well, cook well. That's all. Don't look for nose. We have no specific nose to eat. So one question is, can meningocele be made out by ultrasound? Yes, it can. Some, especially meningomyelocele, yes, very much. Very small meningoceles may be missed, but usually yes. Neural tube defects are well detected on scans. What are the congenital deformities that can happen of iron ingestion in the first trimester? No specific defects as such. We don't give it in the first trimester because all iron medications tend to trigger a lot of nausea, acidity, vomiting, and the girls are already grappling with a lot of vomiting, distaste, and acidity in the first trimester. So we wait till she crosses 13 to 14 weeks and then start them on iron. Are there any long-term implications for vaginal delivery versus Lses? Yes, sir. If you see all our studies, all our textbooks, there are hundreds and thousands of studies. Oh, okay. Not really. See, autoimmune diseases somehow, they have been very friendly with pregnancy. Okay. So the question is, are there any studies regarding the long-term implications for vaginal delivery versus Lses? Specifically for women with autoimmune diseases. Okay, so as I was telling, most of the autoimmune diseases behave very well in pregnancy. Most of them show a remission. So we find normal versus, so no, nothing specific that. No, and Okay, so that's a general thing that they feel that the lungs, the fluid is squeezed out. They have less incidence of transient tachypnea of newborn, but nothing specific with autoimmune and impact on the children.
Any other question? Online, I will check the chat box. I think. Wait, 1 minute.
Yeah. So sir was asking what about the role of multivitamins. So most of our iron preparations and calcium to some extent contain B12, zinc, and we are just happy. So the WHO says that no need to specifically supplement with again vitamins. And the most common questions they ask is DHA, omega. We tell them if you want to take, you take, but they're not the standard recommendations that WHO or any national health program expects from us. They say one fruit, 1 cup of curd will suffice for all the vitamins that we are expecting. Unless the girl specifically has some specific vitamin deficiency, like B complex deficiency, angular stomatitis, then we tell them, okay, take some more because it's, but otherwise not required. Most of the things, except folic acid, we start after the first trimester because it helps them retain it better. The compliance is so much better after the first trimester.
Yeah, with respect to multivitamins, the opinion is individualized. If you ask me, in the first 2 decades of my practice, I never believed in giving multivitamins. But as I got exposed to all the information, that micronutrients, macronutrients, so my personal opinion is, however best nutritious diet we take, definitely there will be some short coming in, particularly our Indian diet, because we make it very spicy, tasty, etc. So I feel supplementing vitamins from my side, yes, I believe in that. How about you, Dr. Anita? Not very particular. So she insists on a good diet. Iron, you're particular. And also calcium, adequate calcium, in addition to the diet. Honey during pregnancy. Dr. Anita.
All these minor food. So, what about the use of honey, harm or benefit? We haven't had any. I haven't come across any specific study. I should look up after you ask. But when girls ask me, I tell them take it. If they ask me 3 times, I tell okay, avoid. So ground rule is everything is safe unless you eat raw uncooked food or. Sushi. Yes, uncooked. Thank you.
So, Dr. Swaitha is ready. So, over to your talk. You don't need this, no? You have a hand.
Warm welcome to everybody present here. Slide delay because most of my slides contain videos. I think for the Zoom meeting, the video can't be played, unfortunately, but those who are here can see the video. So I will be just talking in brief about how recent things have changed in obstetrics and gynecology. What were our earlier concepts and what new things have changed? So I'll be talking about recent changing concepts in gynecology and obstetrics. So the only thing constant in life is change, and our ability to adapt to these changes will determine our success in life. So there was a time, like when we were doing PG and all, it was called vocal anesthesia. Like we used to just yell at the patients and tell them just bear with it, especially while suturing our episiotomy and all. It used to be a busy labor room. We used to just yell at our patients, okay, 2 minutes, I'll finish it off, don't yell. Then came a time where the doctor is dancing with the patient to help her overcome the labor pains. So we are so concerned about, especially in urban setting and private practice, we are so worried for our patients. So individual care is given and doctor is even dancing with the patients. And now is the time where the patients are only attacking the doctors. And the thing is, save the doctors. That is the thing, how the times have changed. From where we used to be the dominant thing and doctor was considered God and whatever the doctor said was considered good. Now it has come to the thing, each step, each thing we do, we have to be careful and actually be scared of the patients. So coming to the actual topic, earlier abortion, that is MTP, was allowed up to the age of 20 weeks of pregnancy. But recently it has been extended. So medical termination for any reason, be it fetal anomalies or for maternal concern or any reason, it is allowed up to 24 weeks of age. So, and even that, so at one end we have the extension of the MTP till 24 weeks at the other end, while earlier in India 28 weeks or 7 months was considered, or 1 kg was considered as the period of viability. That is, any time the patient comes before that with pains or leaking or anything, we used to consider it as abortion. But now times have changed. So even after 24 weeks of pregnancy, we are considering it as period of viability. So even 600 grams, 550, 700 grams, we want to give that child a chance. Of course, there will be a lot of long-term morbidity and financial burden on the patient. But after discussion with the NICU team, if the patient, especially in IVF pregnancies and all, where we know how difficult it has been for the couple to conceive in the first place. So even if they come with leaking or pains at 25 weeks, we don't want to give up on the child. We don't consider that as abortion, and we try to salvage the child. And these children, especially in the short-term follow-up, they have been doing well. So we don't, especially if they are close to 25, 26 weeks and close to 800 grams. So when it comes to gynec, earlier like multiple fibroids, big fibroid was considered like a dangerous thing, and we used to take consent for even hysterectomy, and there was no chance that only laparoscopic surgery would never be advised. But nowadays, no matter what is the no matter what is the size of the fibroid, how big the fibroid is, how many, even 28 weeks. So even 28 weeks, some of the videos are not being played. Even 28 weeks, even 12 centimeter, 13 centimeter, we are able to do it laparoscopically through minimally invasive surgery. It is very comfortable. Hardly the patient stays in the hospital for 2-3 days through small holes, and earlier, so complete rest for hospitalization for minimum 4 to 5 days, and then further rest for 3 months, and all that was advised. But nowadays, even hysterectomy we are doing daycare. Patient comes in the morning and can go by night. So it has become so comfortable, and the morbidity is so less. The chances of infection, blood loss, the analgesic requirement, hernia, all that has reduced. So even fibroid removal at during cesarean was a complete no earlier, like it was absolutely contraindicated, saying that there'll lot of bleeding at the time of cesarean and lot of vascularity will be there during pregnancy. But nowadays we are even removing fibroids at the time of cesarean, any number, any size. Of course, patient even their dual surgery is not required. That does not mean anybody with fibroid should have a cesarean. If there is an indication for cesarean, at the same time, we can, after taking consent of the patient, we can do fibroid removal at the time of cesarean. So even, can you directly PowerPoint it over? Because it's the last talk, I think everything is okay. So even endometriosis and all, earlier endometriosis was considered like a big this thing, because there's lot of adhesions, big cysts will be there, bowel will be adherent, ureter will come in the way. So, but with the advent of laparoscopy, where we have a good retraction, all these bowel and all retraction is good, visibility is good, and magnification is there. So we are able to do good justice to these patients and good relief of their, usually they present with severe dysmenorrhea, large cysts, or severe lower abdominal pain and all this. So with laparoscopy, we are able to do good adhesiolysis, release all the adhesions. Next slide. So release all the adhesions. With both blunt and sharp dissection. So we are seeing here that uterus is fully retroverted, both the ovaries are stuck, the bowel is adherent. So with good laparoscopic techniques, yeah, though it has to be done by a skilled person, but we are able to separate the bowel and all, and they are able to have good pain relief both post-surgery. And no matter how big the ovarian cysts are, even early stage ovarian malignancies and all, large cysts, even up to 28-30 weeks cysts can be, next slide please, can be decompressed laparoscopically through small incision. See, this is after all release, how it was at the beginning and how everything and all the endometriotic spots have been burned and the ovaries released, the cyst has been removed, the bowel has been released. So because of these adhesions, they have lot of pain and they get good relief post-surgery. So with laparoscopy, all this, because of the magnification and keyhole, next. So it has been possible. Even pregnancy with, this was a case of 14 weeks pregnancy with torsion of ovary. So earlier open surgeries had to be done and a lot of risk was involved, but now comfortably we are doing laparoscopy, especially after any emergency procedure at any point it can be done. But elective surgeries we are doing it laparoscopically after 12 to 14 weeks of gestation. So in this case, next slide. So we did detorsion, just she had presented with acute pain, we did just detortion and then she had good pain relief and the pregnancy continued. This was one more case of a large ovarian cyst with constant dull-aching pain. This was some 12 centimeter cyst or so. Next slide. At 14 weeks of pregnancy. So this also, we just did decompression of the cyst. Yeah, we have to consider there is a risk of, always we have to consider the risk versus benefit. Just thinking that there is pregnancy, even if it is any cyst or appendicitis or anything, we should not leave it thinking that she is pregnant and we will manage it conservatively, because the complications can happen if it is not addressed at the correct time. So now, no matter, next slide, no matter how big the cyst is, till up to 24, 26 weeks also, we are able to do surgeries for ovarian cyst, torsion, appendix, laparoscopically, even in pregnancy. So this is a case of corneal ectopic. Ectopic in tube is very simple, easy to detect and easy to handle also. But corneal ectopic, because it is attached near the edge of the uterus, so the chances of bleeding is high, and earlier, again, this was considered a very high risk case, and we take consent for hysterectomy and death and all that. But nowadays, we are able to, next slide please, with the availability of vasopressin, which we routinely use in cases of multiple fibroids or anywhere where we expect a lot of bleeding. We use 20 units of vasopressin in 200 ml of normal saline, inject it into any large size uterus, multiple fibroids, or in these cases where we expect bleeding. So it causes good vasoconstriction and blood loss will be minimal. And we can, by the time, the duration of its action is approximately around 40 to 60 minutes. By the time we finish the surgery, even earlier it was considered that it may cause any secondary hemorrhage. That is, once you finish the surgery, the patient may have bleeding problems and all, which may not be detected at the time of surgery. But we have done so many cases using vasopressin and not encountered even a single case of any secondary hemorrhage. Though it has to be used carefully because it can cause sometimes intense, if it goes intravascular, it can cause intense vasospasm, bradycardia and all that. So the anesthetist should be good enough to recognize these, and we have to make sure that we don't inject it intravascularly. So this is that same case of corneal ectopic where we have excised the entire thing, and because it's a wide area, we are suturing it back so that the next pregnancy she can have, normally without any risk of any uterine rupture. That is the sutured uterus. So even this is a case of laparoscopic encerclage. So it is usually, encerclage is put for any recurrent mid-trimester. So after 12 weeks, recurrent abortions, initially they try with vaginally, McDonald's encerclage is put. Even if that is not helping, we are putting laparoscopically at the level of internal os itself. So where the outcome, next. So this is where we put it laparoscopically. We put Marceline tape, and it's such a simple procedure, and the pregnancy will carry up to term, so 36 to 38 weeks. Only thing is, cesarean has to be done for such kind of cases, and normal delivery is not possible. And once put, it can be used for subsequent pregnancies also, second or third pregnancy. So So the same encerclage, we can put it even during pregnancy. If the patient presents with short cervix, we have tried a vaginal encerclage and it has not helped. Even during pregnancy, 12 to 14 weeks, we can put laparoscopic encerclage. So always when we think about mid-trimester abortions, we should consider any uterine anomalies like septum in the uterus, any unicornuate uterus and all that. So this was a case of, again, mid-trimester abortion. So we detected there is a septum in the middle. So this is the septum there. I think it is not compatible, so it is not playing properly. So it is a simple procedure. Hysteroscopically from below, we cut the septum with scissors, and then the patient usually has uneventful next pregnancy. So it is such a simple thing. This septum can cause recurrent, even first trimester or second trimester abortions. Hardly the procedure will take 10 to 15 minutes, and we can cut the septum with scissors, and subsequent pregnancies, will be uneventful. They won't even require any cerclage or anything in such case, if septum is the cause for the abortion. So even big hysterectomy for big uterus or any complicated cases, earlier laparoscopy was a big no-no. But now, because we have understood how it works, we have advanced instruments, we have good magnification, we have even 3D laparoscopy where we are able to see things clearly, we are able to dissect better, and even large uterus, any adhesions, we can do it laparoscopically. And even morcellator is available where, we can, with the use of that morcellator, we can remove the fibroids or the uterus into small bits and then finish. Larger incision is not at all required. To 10 to 15 mm, we can finish off the entire procedure. So this is just to stress that earlier a more conservative approach, a more open approach was being used, but nowadays we are more proactive. Okay, anything, if there is any problem, we better to deal with it rather than treating it conservatively, allowing it to go for any complications. And any complicated cases can be dealt laparoscopically, no matter what size, what number, even early malignancies, anything can be done laparoscopically. Next. So 1 kg, 1.5 kg, anything can be done laparoscopically. When it, just madam wanted to, because this is entire month is Cancer Awareness Month, so madam had requested me to just speak a little about Choreocarcinoma. Choreocarcinoma is, we don't see it that frequently. It is one of the very rare cancers. It can be seen both in men and women, though very, very rare in men and more commonly in women. It can be both gestational, that is associated with pregnancy, and non-gestational. Again, associated with pregnancy is more common. Usually follows pregnancy. It can be any pregnancy, like normal delivery or abortion or missed abortion, ectopic pregnancy, any pregnancy event it can follow. And if the patient presents with any abnormal uterine bleeding, we have to have, especially a post-molar pregnancy. Molar pregnancy, of course, we monitor them with beta-HCG till it becomes negative. So, but we have to follow up these versus we have to have this at the back of our mind about Choreocarcinoma. Any abnormal uterine bleeding post a pregnancy event, any kind of pregnancy. And they may also, because they will have high levels of beta-HCG, they may present with hyperthyroidism, or they may present with even metastatic symptoms like breathlessness or hemoptysis or seizures or anything. So post-evacuation, if there's persistent beta-HCG more than 20,000 post 4 weeks, or after evacuation, even if the values are falling down, but still there post 6 months, we should have this Choreocarcinoma. Yeah, of course, post-abortion and all, we send, usually missed abortion and all, it is, or retained placenta, we send the tissue for biopsy, and if it comes as Choreocarcinoma, if have to refer it to a, usually it is handled by oncosurgeons only, and whatever chemotherapy is necessary. So this brings me to the end. And also IVF, I wanted to just push this thing. So earlier we were doing third-party reproduction, that is donor, surrogate, and all more commonly. And especially in indicated case, it used to bring a lot of joy to the couple who is anxious to conceive. But currently, third-party reproduction is banned, and the proper board has to be formed, and for the next 3 months at least, surrogacy, donor, transfer, everything is put on hold. So like how kidney transplant has to go through a board, even this donor, surrogate, even donor IUI, everything has to go through a board, and then only after permission, only after this thing only we can proceed.
Thank you, Dr. Shweta. Any questions, audience? We'll move to the chat box. There are a lot of questions in the chat box. Any questions? So I now request our senior FPA member, Dr. Ganapathy, to honor our speaker. He is very regular and a front bencher. Thank you. Stand for the photo. Thank you. I'll move to the chat box. Okay, questions are here. It's easier. So for the first one, no, go for first one more. Is that no chat box below that? Thanks for joining, Dr. Shyam Sundar. Okay. Okay, Dr. Raj has joined from Canada. Thank you, Dr. Raj. He's also an obstetrician, my classmate. Dr. N.P. Viswanathan is also there from US. Dr. Sabapati has a question. He wants to know if risperidone, olanzapine and other antipsychotic medication can be given to a schizophrenic pregnant woman. Does it cause any cerebral or ventricular CSF abnormalities in the fetus? Could you come here? Camera is focused.
So we do give all these medications if required. Olanzapine more is associated with diabetes in pregnancy, more in chances of it occurring in pregnancy, and some side effects, but then most of the times they're safe and we give. We are only very particular about lithium. We don't want that to be given unless absolutely necessary.
Which iron preparation, considering the GI side effects? You are very clear on your slide. Once again, you can reiterate.
So if we are looking for, see, most of the irons are fine. If we are looking for specific preparations with the brand name, then we have something called Solfi. It is more of elemental iron, 30 mg. It's supposed to have the least side effects. And there's also an organic iron called Solgair, which is available on Amazon nowadays. So these two are supposed to have the least side effects. If a woman has a lot of GI effects, ideally it's supposed to be taken on empty stomach, but then we tell her push it and have it either with food or after food. But otherwise, more or less, all iron preparations have the same effects.
Listeria can cause chorioamnitis without SROM, may lead to IUFT. Your comment on that?
Such a rare disease. Yes, it can cause chorioamnitis, but any infection left unattended and associated with rupture of membranes can, yes, eventually lead to an intrauterine fetal death.
Thank you. Thanks, Dr. Raj. Pasteurized honey is safe. Yeah, that's what Anita has told, because unpasteurized can cause infection. Dr. Sabapati's question is, Fibroid of any size, can it be removed during cesarean section?
Usually it can be removed, but if they are multiple and big size, it would have been difficult for the woman to conceive in the first place, or they may have abortion also. So what we see at cesarean is usually 8 to 10 centimeter, or small many may be there. So bigger than that may have caused infertility or may have caused abortion.
But when it comes to the medico-legal aspect, we are supposed to take adequate consent.
Yeah, consent.
Yeah, so without consent, intraoperatively, if we notice any other lesion, fibroid or otherwise, we are supposed to defer and then again reoperate, but still cannot operate. Kindly.
Usually these fibroids are picked up on ultrasound when they are doing, because they would have had so many scans during the pregnancy. And yeah, we do explain to them, okay, it is not accepted by everybody, okay, fibroids to be removed. But since we are doing it routinely, we are comfortable. But it has to be explained to the patient. Consent for any surgery, even if it is multiple or whatever, they have their own risks, and we can't say no. Even a simple case can go wrong at any point. And when we are expecting, okay, this is a complicated case, all the risks and everything has to be explained to the patient. Even when we operate on endometriosis case and all, we have to explain to them the risk of ureteric injury, bowel injury, everything, and then only proceed. Because these are complicated cases and we can encounter them, and patient should not be surprised. Consent definitely is the best first thing. Without that, we can't do anything. That's what I said in my first thing. Okay, now every step we have to take carefully and with patient's consent. The options have to be given to them and they have to choose what suits them.
Yeah, that's what. Only thing is whether you're going to operate a small or a bigger fibroid, either way, for us with respect to medico-legal issues, the take-home message is whatever you have taken consent for, only that particular surgery we are supposed to do. Suppose you find inflamed appendix while you are operating, you cannot, if you have not taken a consent, we are supposed to close and then again take consent and reoperate. So that is what the law says. And so Dr. Sabapathi's question was fibroids, no? Of any size, can it be removed? So you have given that the fibroids would have been picked up sound, and accordingly you would have been prepared to remove them. Then very professional presentation. Please elaborate on evaluation for elderly primary for Downs and other related disorders.
That question has an essay answer actually, but to concisely tell, elderly primary is no longer a term we use. None of our women like it, because when we were postgraduates, more than 35 was considered elderly primary, but now most of the women conceive in that age grade. I would say more than 44, 43 may come in the elderly primary group. But as I said, it's a long answer, but to cut it short, for all of them who had higher risk for Downs and other chromosomal abnormalities, we nowadays offer them something called NIPT, non-invasive prenatal testing, where a blood sample of the mother is taken and we look for fetal blood cell, fetal DNA and fetal cells, and that is supposed to have about 99% sensitivity. So this has become an alternative to amniocentesis that we would initially offer in the previous years. I think that answers.
So he's asked evaluation for elderly primary for Downs and other related. See, yeah, but I think as a dictum for all women, irrespective of the age.
Yes, so irrespective of age, for everybody, we offer something called the double marker test or the dual marker test along with the NT scan. So that has a sensitivity of about 95%. But then when we think she's at particularly high risk of a chromosomal abnormality, then we move on and offer them this blood test called NIPT.
Hope Dr. Sabapathi's, Dr. Gayatri's question is answered. That's all. We have questions in the chat box from the audience. Any questions? Dr. Ganapati? Yeah. Sir, we'll give the mobile there.
I got one woman patient who has done cesarean 15 years back. Now she complains of recurrent abdominal pain, and she has got the bowel adhesions to the uterine scar. Then this case you are doing, or the general surgeon will do it?
Yeah.
Multiple fibroid, she was operated there in Africa. It was a midline scar. All she had, when we did ultrasound, the fibroid was very small, hardly 2 centimeter or something. That was not the reason for her pain. Even her MRI and all did not pick anything. But whenever there is a scarred abdomen, we always have to think about these adhesions. So when we put in a scope, the entire abdomen, there was omental and bowel adhesions. So we released it slowly, and to reach to her uterus, it took us 1.5 hours to release all the omental and bowel adhesions. But once we released that, because her primary thing was both pain and fertility, and even that small fibroid we didn't want to leave. So we removed that. After that, she was so happy that pain relief was there. But only thing about these adhesions are, they are known to recur. So we do have something called as interseed and all, which we use to decrease the chance of adhesions. But one, we have to always inform the patient that there is a chance that these can come back. But we are able to release it quite very well with omental adhesions, bowel adhesions.
Kindly repeat. The medical illness.
Usually, these hernias are, whenever we talk, even when we get incisional hernias, we usually don't blame it on the method of closing or the surgeon cannot be responsible. It is the reason patient gets, usually tell them it is their inherent problem. Their connective tissue is weak, because we can never let our doctor colleague or anybody down, or we cannot comment as to how it was closed and in what circumstance it was done. So we always tell the patient and counsel the patient, it is the inherent connective tissue weakness that has caused these hernias. But whenever we are seeing patients, whatever be it, being operated by another doctor, it is basic ethics to say that this could have been done by anybody, or it is not the doctor's fault. That is this thing. And in today's time especially, I think we should be careful about what we are communicating with our patients.
If when it comes to practicality, with my nearly 4 decades of practice, incisional hernia, I feel you have a precipitating factor. You would have become diabetic or etc. And if you take my example, tubectomy patient, post-tubectomy, she had incisional hernia. And when she was being investigated for operation, we came to know that both are HIV positive. So there is some precipitating factor, nutritional, or as she put it, the strength of the abdominal muscle, something. Otherwise, yeah, it cannot happen. Or they're post-operatively, they're asthmatic. They wouldn't have taken adequate rest. Everything adds to it. So, and another thing is, in the last CME that we attended from Altius Hospital, Dr. Ramesh was saying, the first and foremost thing that we all need to learn is not to talk ill about the previous doctor, because 2 years back or 10 years back when that doctor was operating, we don't know exactly in what situation the doctor was operating, and we have no right to say. Sitting here, I cannot comment whether my patient needs surgery in Cesarean in indoor. That doctor has to take a decision. So I think that's what he was trying to tell us, and he also asked us to keep IMA to work on the population stabilization also in addition. to the CA cervix prevention, etc. and all that. Yeah. Okay. Yeah. He's satisfied with the answer. Okay. Any, Captain, you have a question? Can you come here?
I think we'll catch you. The only speaker who hasn't been covered in the questions, Dr. Vasu, the childhood cancers. Especially I like to know about this. These days a lot of junk food and Pepsi, Coke, whatnot the children are eating. I just want you to highlight on any junk food. I mean, of course, junk food is, anybody knows that junk food is junk at the end of the day. Any special sort of advice you like to give for the parents to avoid any specific food which can be carcinogenic later? And just highlight on special dietary requirements, special recommendations for the parents for the special.
Thank you for the question, sir. This is a question that is very often asked to me by most of the parents. They ask that, did we feed anything wrong, you know? The answer to that, no one knows. Because there are no randomized actually trials actually seeing, you know, whether this child ate any junk, a lot of, you know, preservative food, comparing them with other children. So we really don't know. But as a general thing, definitely yes. All the food that's coming packaged has a lot of preservatives. The problem is with the preservatives. So we do know as such that in higher concentrations, they are carcinogenic. No doubt about that. So as much as possible, natural homemade food. With children, you can't really, you know, strictly say, don't eat this, don't eat that. So once in a while, definitely outside food can be allowed. But with terms of as such lifestyle changes like obesity, we are seeing those kind of disorders more in children now, early onset diabetes, obesities and things like that. Even those can be a risk factor for certain kinds of cancers. So yeah, maintaining a healthy lifestyle, exercise, play, all those things are definitely more important. We really don't know whether, you know, which particular food, like for example, parents ask me, Maggie, can we give Maggie? So it's very difficult to point out and say. But yes, homemade fresh food is the best. Yes, yes, yes. Absolutely, yeah. Avoid it, yeah. Correct. Absolutely, yeah. So they just want fast food, whatever fills their tummy as soon as possible. And very sadly, parents are okay with it. So anything to, you know, keep the baby quiet. So just get one packet of kurkure and they'll be happy with it. So I think that kind of habit has to be discouraged. Absolutely, yes, yes. Thank you.
We cannot ask a child not to eat Maggie or not, we cannot, when you yourself don't have control about your likes and dislikes, we have no, we have no authority to say that the child should not do this, etc. If you ask me, I say you continue to eat because we are human beings. I don't think we should differ from anything. But the frequency of junk food, the quantity of junk food we can take care. And when a mother or a grandmother comes for treatment, I tell them, like, you and me are already old. It is your grandchild who has to follow what has to be taught. So if the grandchild is outside, the grandchild is brought in, and in front of the grandchild, the grandmother or the mother, etc., they are counseled about what to do and what not to, because tomorrow they will be better citizens and healthier. So I think coming to junk food, yes, as you put it, and then some of our mothers will say, my daughter likes kebab very much, my son, he has to eat. So I tell her, why don't you learn to cook kebab and prepare and give it to him? Otherwise, get one plate and all of you share and let him eat less. At least when we get a chance, I feel that's how I put it. And if there are other questions, I think we can take it over dinner. And online, any questions in the chat box, we will pass it on to the three speakers, and they are always ready to answer. So we now end our session, and before we end, definitely we need to show our gratitude and sincere thanks to our sponsors, the Rainbow Hospital team, the Proteinx Makers team, as well as the audiovisual team, and the hotel for providing us the fellowship dinner. So for acknowledging our thanks, I call upon our President, Dr. K.N. Harish Kumar. the Rainbow Hospital team, we have Mr. Sudhindra Bhatt and Mr. Farah Ahmed. Could you come over? They have not come. Okay, fine. Are they coming? Okay, they are outside. In the meantime, Kiran can come. Terence, Shaktivel, all of you can come. Kiran is the marketing head at Rainbow Hospitals, shifted from another corporate hospital. Terence, manager marketing. Shaktivel, assistant manager. Kindly come.
Thank you, sir. Thank you.
I'm standing. Okay. Our last webinar, we had the privilege of listening to Dr. Rakshay. All of us were very happy with the take-home message. And Kiran, certainly one caller to your team, because Dr. Rakshay did very well. We acknowledged, we did benefit a lot from his last talk. And today all the three speakers have excelled. They've done a wonderful job. We have liked in the sense that we have had a lot of take-home messages from them. More questions will pour in, we will pass it on to them. So now it is Mr. Terence. Yeah. Bunny. Thank you. Yeah, Mr. Shaktivel, manager. So he covers our area. Thank you. The general managers come? Sudhindra and Rahman. Okay. So the Proteinics team, can I request them to come? Yeah, together. Correct. Mr. Basha? Yeah. Okay. A certificate for
Yes.
acknowledging your participation and support. Yeah.
One photograph.
Yeah, il bani ನೀವು ಕೊಡಿ. Come.
Thank you very much. Thank you.
Harish. Thank you. So now before closing, we will speak about our upcoming CMEs and webinars. IMA, we are having a webinar on Tuesday, and yeah, so I request you to log in on Tuesday, coming Tuesday. The link will be shared with all of you. 4 to 6 we have a session from the HCG hospital team, and the talk is going to be one on anemia, another one is on blood cancer, and mainly anemia is one thing that all of us should keep in mind irrespective of our specialty. No patient of us should walk out of our chamber being anemic is my motto. And Harish, the next webinar for CME for us right now is on March 20th. Before that, yeah, we'll let you know. March 20th we have a webinar. No, CME, we have a CME, yes. And last but not the least, with the permission of the crowd, IMA is our mother body. So I request each one of you to be part of the mother body, because we together need to fight for our rights, and we need to lift our head and walk about, command more respect. So my motto is always first and foremost is first to equip ourselves, be updated with our academic knowledge so that we will be able to treat our patients better. Next, most important, or the first most important, is about counseling. The way we speak is very important. So all these messages we are trying to get through different webinars and CMEs, and of course suggestions are welcome. And being IMA member, if we are less than 60 years, we need to utilize the benefit of Social Security scheme. And all practicing doctors, we have coverage up to 1 crore with a paltry 3,100 rupees for the first year, the professional indemnity. Subsequent years, it's 500 rupees plus the overheads. And in addition, we have another health insurance scheme. The coverage as of now is only for 2 lakhs. We plan to increase it based on the number of doctors who enroll for KSHS scheme. And of course, as we all know, at the headquarters also, our president is doing a good job with respect to fighting mixopathy and any issues that that we are now facing. And in Karnataka, as of now, with respect to KMC renewal, the case is in court, and as of now, we are all required to do the renewals, and we are requesting them to extend it to 2023 till the court order comes. Because right now, all of us are renewing with, yes, of course, we are all renewing, but the problem is the renewal has to happen with credit points. So KMC itself is erring by taking the renewals without the credit points. So none of us have been asked to give our credit points. We have been doing the renewals. So till the court order comes, we are trying to get the extension, that is without we paying the penalty. As of now, we are all paying the penalty. And regarding KPME registration also, renewals also, lot of practical difficulties. And trade license we can avoid if in case we register with MSME. I will get more details through WhatsApp subsequently. This is all about IMA that I wanted to speak. And okay. So Mr. Sudhindra Bhatt and Mr. Farah Ahmad. So Mr. Sudhindra Bhatt is the General Manager, Rainbow Hospital, and Mr. Farah Ahmad, General Manager, Cluster Head, Bangalore. Kindly come, accept our acknowledgement. Thank you. So we wish best wishes not only for your personal achievement, for the hospital for which you work. Thank you. Thank you, Dr. Harish. So we now close. Kindly join for fellowship dinner, and those who are online, back at your places, have your dinner. Thank you.